Good morning, everyone. I'm absolutely thrilled to introduce today's Grand Round speaker, Dr. Adrian Aguilera, who is Chancellor's Professor and Associate Dean for Digital Initiatives at the UC Berkeley School of Social Welfare and Adjunct Professor in our UCSF Department of Psychiatry and Behavioral Sciences. He is also affiliated with the Computational Precision Health program at both campuses. In addition to these appointments, he's a director of the UC Berkeley Digital Health Equity Research Lab and the Center of Excellence for Behavioral Health Equity. At ZSFG, where he mainly works, while at UCSF, he's a director of the Latino Mental Health Research Program and co-leads Solve Health Tech. Hopefully I got that right. Okay. Dr. Aguilera's research is focused on developing and testing technology-based interventions to address health disparities in low-income and vulnerable populations with an emphasis on the Latinx populations. He has done extensive research with populations seen at the primary care clinics at ZSFG. Dr. Aguilera's current work has focused on utilizing mobile phone technology to improve mental health interventions in primary care settings. He has developed and deployed Healthy SMS, which is a platform for delivering text messaging health interventions and visualizing data received from patients. He has applied this approach to the Mood Text project using text messages as an adjunct to group cognitive behavioral treatment for depression, resulting in increased engagement and treatment. He is also co-PI at the Diamante project, which adds machine learning to improve personalization of mobile phone-based health interventions for individuals with diabetes and depression symptoms. Dr. Aguilera's work has been funded by the National Institutes of Health, the Robert Wood Johnson Foundation, the Agency for Healthcare Research and Quality, and the Health Resources and Services Administration. Needless to say, Dr. Aguilera has committed his career to working in clinical and research settings with low-income populations, and he has made tremendous scientific contributions in our understanding of how digital interventions can be leveraged to improve quality and access to behavioral health care in the public sector. Please welcome Dr. Aguilera.
Thank you so much for that introduction and for saving me some room on a couple of my slides so I don't have to repeat a couple of things. It's so great to be here, so wonderful to see so many familiar faces and just kind of feeling, I have many homes, but this is definitely one of my treasured homes. So it's great to be here and share some of the work that I've been doing and also give you a little bit of preview of some of the things that we're working on coming up. All right, so Fumi already went through this slide, so I'm gonna just forward ahead in terms of some of my roles. I'm gonna start broad just to give you a sense of what motivates some of the work that me and my colleagues have been doing, and then give you a sense of some of the things coming up. So in general, I frame my work at the intersection of digital mental health innovation, health equity, and implementation science. So I really think about, really started this work motivated by improving health equity, reducing health disparities. And as a disciple of Ricardo Munoz, really thinking about innovation and digital interventions. And as technologies are developed, really being mindful that they be used to decrease disparities and improve health broadly, as opposed to doing the opposite. And so the implementation science approach can really help put these things into practice. So as many of us know, there are existing disparities in access and utilization of mental health services by racial and ethnic minorities. And at the same time, there are issues with digital literacy by socioeconomic status. We often hear the term the digital divide. And oftentimes when we hear this, people often say, well, you're working with low-income populations, they can't really access these technologies, right? We shouldn't use these technologies because they're not a right fit. And I think that I disagree with that approach. I think that it does not give people enough credit for the capacity that they may have, even if they don't have access. And I think this has been borne out in a lot of the work that we do. And ultimately motivated by this idea, this quote in one of our papers was Stephen Schuler and myself: if marginalized and underserved populations are not considered during the development and evaluation of digital mental health, these technologies might serve to further entrench rather than overcome existing disparities. So that's really at the core of all the work that I do. And some examples of who digital health is designed for, right? These are some popular ads for devices, primarily kind of these Apple Watches or other wearable devices that many of us might have. And what we see is that targets are often people optimizing their health, right? People that are already relatively healthy, just being a little bit more healthy. Let's say you average 10,000 steps, you get an extra 1,000 or 2,000, right? Well, what if you average 2,000 steps a day, right? And you get an extra 1,000 steps. That's proportionally a much greater increase, right? So that's the kind of approach that I think we need to move towards. And when we dig down a little bit deeper into this, data is a couple years old, but looks at who uses wearable devices, right? And sure, this is probably not very surprising, but it tends to be people that already have good health, right? In reality, this should be flipped. People that need the help likely can benefit a little bit more. So there's a lot of work to be done. When we look at wearable ownership by demographics, there's quite a big disparity in terms of demographic factors, including age, education, and income, which again, not surprising, but I think that it does provide an opportunity to work with folks who don't have as much access and use of technologies to improve their health. Another issue that's at the core of a lot of what we do is expanding language access. So most new innovations in this area tend to be done in English, but as we know, there are many other languages in the world, and even many English speakers in the US and in the world prefer other languages as their first languages. So thinking about how do we reach untapped markets, if you will, using a business term, to help people that otherwise haven't seen other interventions, haven't received an intervention. Too often, we're working with folks who've already tried maybe 1, 2, 3, 4 things, and we're marginally improving outcomes versus reaching people who have never received anything. In terms of private companies, one of the challenges, and I think one of the reasons why we haven't seen as much promise as we'd like to see, is that private companies have not really invested in some of these core elements of working with high burden populations, of measuring impact in terms of outcomes, costs, or access to care, right? They're driven, which given the model makes sense, driven by profit, but that doesn't always align with need, right? And also I think that some of the profit gains that we've seen tend to be short term, and we've yet to see a good sustainable model for applying digital technologies. And I think one of those reasons is that underlying, we have to address the key metrics that matter within the health system, mental health system. My former postdoc, Caroline Figueroa, and the group, which I was a part of, designed this idea of this digital health social justice guide to think about how do we design digital interventions, new technologies to address some of these key issues that are often left out. And we put together a set of questions, right? And so starting off with, as I've already alluded to, thinking about equitable distribution, right? Who is represented in my research and my development? Equitable design, how can I design these tools with and for communities who have need? Considering privacy and data return, assessing the presence of stereotypes and bias, and we're seeing this quite a bit as generative AI is developed and bias in AI, and even factors such as structural racism and broader contextual factors. And these are often admittedly hard to address in individual interventions, but at the very least, we found that it's important to recognize the realities of people's lives and not to put them aside. And although we focus on the individual, people do live within context, and it's important to consider these things. Another framework that's important to think about before I dive into some of the details of some of my work is this taxonomy of mental health interventions which Ricardo Munoz put together. And it's really thinking about how do we blend technology and traditional psychotherapy type interventions. So for type 1, we have your standard face-to-face intervention. It could be your 1 hour a week model or 50 minutes. Type 2 would be that standard face-to-face intervention with a technology kind of on top of it to improve the intervention. Type 3 would be flipped a bit, where the technology is the primary intervention and there is support by some human in the loop, if you will. And then type 4 would be totally automated interventions where people don't engage with any other human necessarily. Maybe you're enrolling in a study if it's part of research, but otherwise it's all self-help. And so I'll give some examples of some of these in some of my work, and we'll see kind of the pros and cons of these approaches. All right, so I'm gonna just start by giving some motivation for kind of getting involved in this work. And this is really considering the implementation of cognitive behavioral therapy for depression in the public sector, more specifically in primary care clinics at the general hospital. So some years back, we did some kind of descriptive exploratory assessment around outcomes in group CBT for depression at the general. And we found some basic facts that are probably not surprising. Attendance predicts improvement, right? People show up, they get better, right? It's a dose response effect. However, there's a good amount of dropout, low levels of homework completion, and people tend to not complete the treatment, right? So there's a lot of adherence, engagement challenges. And so we started thinking about how could we leverage text messaging, which at the time there was less access to smartphones, so this was a way to reach more folks. And so leveraging texting to improve treatment quality and engagement. And so we added on a text messaging adjunct to the 16-week Bright manual for depression, comparing a group that got the standard intervention and a group that had the intervention plus texting. We sent them mood monitoring text messages on a daily basis. So what's your mood right now on a scale of 1 through 9, and respond back with what you're doing or thinking right now. We reinforced the themes of that week. So whether we're talking about cognitions, behavioral activation, interpersonal interventions, et cetera. And then we also would send medication reminders if people wanted them, and then attendance reminders. And what we found after when we compared these two approaches of standard approach with the text messaging adjunct is that folks who got the texting attended twice as many sessions. So still only 6 out of 16, but it's over double the number that people were attending in the standard group. And more dramatically, folks who received texting stayed in treatment much longer. So out of 16 weeks, they tended to drop out around week 13 and a half compared to 3 weeks. And so you can see if you go back, the standard treatment 3-week dropout looks pretty similar to the 2.5 sessions, right? So they kind of stop attending and probably don't come back. With the texting group, there's this sense of continued engagement via the automated messages. So we know that depression symptoms wax and wane over time, but when people were motivated enough to come back, they were still getting messages and they were able to re-engage. So we found that this text messaging adjunct can decrease treatment attrition, and we can help more people get better. And you know, this was done a few years back, so we've kind of moved on to some extent with beyond texting. The idea, I think, still holds that these technology adjuncts on top of standard care can help improve adherence and engagement in our interventions. We also asked people for feedback. What do you think about the intervention? And here's what some of the folks in our testing group, these are some English speakers. And you can see these are all things that as psychotherapists we'd like to see, that it triggers self-examination. I look into the proverbial mirror, a lot of self-reflection, self-monitoring. That's wonderful. We asked the Spanish speakers, and they tended to, they said some of those same things, but they also brought in more relational aspects where they said they felt cared for. They didn't feel alone, right? And I think it's important to see the different things that this kind of interaction can bring about, and always reminding us that individuals all bring something unique and different based on their own cultural context. People often ask about suicidality, how we handle that, clinicians in particular. We made it very clear that this was not direct communication, that this was a machine sending messages. And nonetheless, people still feel a connection. So in some ways, we tapped into some of this was a while back, but we still see this today, even in the use of many of these generative AI chatbots, right? People still have a sense of connection, even though they know that it's a machine. We did have some keywords that would trigger a message sent to the research team, but these systems are now more sophisticated. All right, so after that project, we moved into the Diamante project, which it grew from seeing a lot of the chronic illness struggles that patients had in primary care at the general, and also with collaboration with colleagues who were focused on addressing interventions for diabetes. And so we kind of brought these two interests together to think about how can we intervene for both diabetes and depression at the same time using some common elements. And physical activity is a core mechanism in improving health overall, particularly important for diabetes. But we could also think about physical activity as an aspect of behavioral activation for depression. And at the same time, wanted to improve mobile health interventions. And some key factors in developing digital mobile interventions are that they need to be personalized, they need to be integrated into care, and as I've mentioned a few times, they need to be developed with and for vulnerable and low-income populations, right? And so we aim to do this via this study. So again, really trying to lift up innovation and lift up health equity at the same time. So I already mentioned kind of the core element of physical activity and that really being our target. When I talk about vulnerable populations here, I'm referring to folks from low-income backgrounds, people with low health literacy, and people from ethnic minority backgrounds. Again, these are not groups that typically are the first ones that are consulted when developing interventions. And so what we wanted to do is to increase personalization by applying a machine learning algorithm, more specifically, reinforcement learning algorithm. And the motivation for this is that most of these interventions often are not personalized. Even today, if you get an app, it's pretty standard what you see versus what somebody else might see if you download it. And even when we do group level or cultural adaptations, which are very important, they don't always get at the individual differences. So reinforcement learners, which I'll go into a bit, can take the data about, let's say, somebody's physical activity and start to learn which types of messages are leading to more physical activity, and therefore improve the outcome by sending the right combinations of messages. So what we did is we had folks download an app, we track their steps via their smartphone, and then we personalize those messages using the algorithm to target specific motivators. And we focused on utilizing the COM-B framework, which is kind of a popular framework in implementation science that brings together a variety of behavior change theories. And at the core, the idea is that behaviors are motivated by improved capability, improved motivation, and improved opportunity to engage in those behaviors. So we created messages within each of these categories. And this is one of the things that the reinforcement learner pulled from. And so it would send out a message about capability and start to learn over time how this one impacts physical activity compared to motivation or opportunity. As an example, a screenshot of the apps. It's pretty straightforward, just really mostly served as a step tracker. And then we sent text messages providing feedback on amount of physical activity and then a motivation message. Here's another kind of example of a couple of types of messages. So they'd get these two messages every day, although some days they might get no message if the reinforcement learner was kind of trying to test that out. So I'll go briefly into what the steps are for choosing messages, just so you get a sense of how these algorithms work. So reinforcement learning is a part of machine learning that really focuses on how the software agent or algorithm is really just focused on maximizing the reward. The reward here is physical activity. So it takes actions which are sending messages, considering contextual variables, which are things like demographics, what somebody's done in the past, using the reward, which is the outcome in this case, again, physical activity, and then has we'll talk about model, and this is how we predict what the reward's going to be and making a calculation for that physical activity outcome. So we sent feedback messages. So first feedback around your physical activity in different ways. We sent those motivational messages that I mentioned. And then we also varied the time of day that messages were sent. So there were kind of three algorithms being processed at the same time. These are some of the contextual variables that we used. Largely was how much somebody has walked in the past, along with some of their demographics and when messages were sent. All this gets put together and then calculation happens, right? So this is an example where the algorithm might calculate that the benefit message is likely to result in more physical activity. So there's going to be a higher chance of sending that message. However, the algorithm does not always send the highest rated message because there are often combinations of messages. Maybe if you can imagine, even if it's an effective message, if you get the same message every day, it's going to lose its effect. So these algorithms are interesting because they're able to test out various combinations. And it's all based on the data, which is important. And so for this project, we worked again with patients at the General Hospital via primary care clinics. And these are all patients with diabetes diagnoses and elevated depression symptoms. Unfortunately, we started recruiting in February of 2020. So we all know what was going on there. So we had to do some recruitment online to balance this out, which was a good and bad thing. The design of the study was we tested this adaptive intervention. So this is a reinforcement learning intervention. And we compared that to sending messages at random, right? And then we also had a control group that didn't get any messages. They just got the app and were asked to track their steps. Here's an overview of the participant demographics. And we see a fair amount of diversity. We got a lot of Spanish speakers, which are primarily folks at the General Hospital, varied levels of education and employment status. And when we looked at the outcomes, we found that indeed, folks in the adaptive arm did have increased rates of physical activity over 6 months compared to the control and random group. Okay. So that we were excited about that. To be honest, we weren't sure after COVID and the recruitment challenges what was going to happen, but we found that there were improvements. And even more interestingly, something that we're diving into a bit more is that the patients at the general benefited even more than the folks that we recruited online. And I think there are various reasons for that. I think one, again, remember I mentioned integrating these interventions into care, right? We also did most of our development was focused on these folks. So that probably helped as well. I think another factor is what I mentioned is access to these types of interventions. For folks at the general, it's likely the first time that they're engaging in something like this versus folks that we recruit online or a little bit more tech savvy may have already tried out something that's similar or along the same lines. So personalization with machine learning can lead to improved outcomes. We can test this in resource-constrained environments that can then be relevant to broader populations. Kind of along the same time, once COVID happened, we needed to figure out how to respond to this. And we had the Healthy SMS platform, which has been the basis for a lot of our interventions. And we decided to create a text messaging intervention along with some colleagues here at UCSF working with adolescents, and all just kind of came together to think about how can we leverage this intervention to send kind of emotional wellness messages to folks who are struggling during this really sensitive time. And we didn't really think about it even as a study necessarily. We thought about it more as a service initially. And so the Stay Well at Home program, Bienestar en Casa program was developed and really integrated CBT and DBT elements where folks got 2 messages a day about basic things such as sleep hygiene, mindfulness, etc. So we had different phases. The first phase, as I mentioned, was something that we just put out there and recruited folks and thought about it more as a service. We did see some improved outcomes over time, but it wasn't compared. The second phase, we did more community type of recruitment, and it was still in it's kind of the second level. We wanted to assess maybe what's contributing to outcomes. And then the third phase was a broader intervention where we actually applied reinforcement learning similar to what we use in Diamante. So in the first phase, we saw some decreases in PHQ-9 and GAD over the 60 days, but again, there was no comparison point. So it's a good signal, but it still can't tell us exactly whether how effective the intervention was specifically. In the second phase, we did a purposeful recruitment of Latinx folks, and we found when comparing Latinx folks with non-Latinx white folks that they tended to improve more after getting this intervention. And I think an important, from the qualitative analysis, we also found that only the non-Latinx white users stated that the Stay Well program provided no new information than they already knew from therapy or other sources. So I think this, again, it's not definitive, but it contributes to this idea that we're reaching folks who otherwise haven't had any other resources. And I think this is a key element in the way we think about our interventions is how can we reach people who haven't been reached before? We're going to get better outcomes by virtue of them not having developed any of these skills versus optimizing for folks who already have had access. In the third phase, we applied the similar adaptive approach to Diamante, where we compared the random with a control and the adaptive or reinforcement learner. For here, the reward function, if you remember that term, was mood rating instead of physical activity. We unfortunately did not find significant differences between these conditions, and there are a few reasons why that might be. There were some differences. You can see the reinforcement learner had a little bit more decrease, but it was not significant. When we looked at folks with mild depression, there were significant differences. So it might be possible that this low intensity approach could work for people who have lower levels of depression, anxiety symptoms, which might make sense, right? If you're really struggling, getting a couple messages a day is probably not enough. You probably need more than that. There are other reasons in terms of the algorithm, the way it was designed, that was more individually focused as opposed to designed at the group level. And that's kind of a little bit of an algorithm design challenge that in hindsight, we probably would have done differently as well. Here's some of the feedback. We also, I think another element was, if you can see from the positive feedback, people actually liked evaluating their mood. So even though we thought of control condition as people getting mood rating messages every day, it's probably not a benign intervention to be monitoring your mood on a daily basis. Okay, so the effects are relatively small for this type of intervention, but they're extremely scalable. If you remember, in the third phase, we reached about 2,000 people, right? So this compares to the studies at the General, where for Diamante, we had about 160 people. The ones for mood text, we had maybe 140 or so. So the scale is different. And we all often want to think about this too, right? So better outcomes, smaller scale, maybe smaller effects, larger scale. We're often kind of playing with these different factors and kind of trying to decide where we want to fall. One possible application for this type of intervention is thinking more on the prevention side, right? So maybe people, they're not quite ready to get into care or have lower levels of symptoms. It's something relatively easy for them to engage with. All right, so now I'm going to tell you about a project that's ongoing right now, which is the Supera project. And again, I just can't get away from primary care at the General Hospital. So we're implementing this intervention in primary care. And what it is providing Spanish speakers in particular with a digital cognitive behavioral therapy intervention called Silver Cloud. And right now we're at the RFPC, the Richard Fine People's Clinic. And then we actually also got some partners through a supplemental grant at the University of New Mexico and University of Arizona, working with rural populations. And these are folks that have depression and or anxiety symptoms. And what we're doing is we're providing them this app, but we're pairing half of them with peer supporters from the community. So this is a group that we connected with in San Francisco, and we actually got connected with them by Lisa Fortuna, who was here previously, and a relationship that was built during COVID. And so we worked with these folks. These are actually our supporters, and it's an example of building capacity. So we worked with them, trained them on what is CBT. They went through the app. How do you become a supporter? And it was really great to see how they were able to engage with technology, even though initially they were really reticent, they were anxious about it. You could see them here kind of all huddled around a computer. This was in the early days. Now they go into our supporter meetings and they quickly log in, check their back end, message their patients, and they're just like professionals. And I think it's really an example of, if we put a little bit of that upfront work in, capacity can be built. And so this study is ongoing, and the design has been primarily to look at the effective support. So how does peer support, can it improve the engagement and outcomes of the intervention compared to standalone app? And then also looking at implementation strategies. This one's been a little bit challenging recently, but we're recruiting via two different methods. One is outreach, so we get a registry of patients that have, let's say, elevated depression symptoms, and we call them and invite them to join the study. And then the in-reach is more via warm handoff type model, where we identify them when they're referred by their primary care physician into the behavioral health team. So we work with the behavioral health team to get folks there. So we're in year 4 of this study, kind of halfway through the recruitment, but we've been learning a lot and kind of excited. We have a small offshoot where we're also going to be recruiting people within the community, and kind of also assessing what that looks like as an outreach strategy. All right. Here's some screenshots of the app. And you can see it's a pretty standard, it's in Spanish, but it's a pretty standard cognitive behavioral therapy app for 8 weeks, talking about thoughts, behaviors, etc. And so for future directions, really thinking about how to combine various approaches. So combine some of the reinforcement learning, machine learning approaches with this peer support model to provide more precision in interventions. Again, continue to target communities directly, not only within primary care, but also outside in the community. And then we're also moving to apply generative AI into some of these interventions and some others. We're currently working on a welcome trust accelerator and proposal to do some work here in San Francisco with colleagues in Mexico City, others in Peru and Argentina to test large language model chatbot interventions for mental health to understand kind of how they work, how effective they can be, but also to see if they're culturally congruent, if they can be culturally sensitive, and probably most importantly, to assess safeguards, as we know that that's been a huge issue with these AI interventions. All right, I think I have a few slides on, these are more thoughts on AI and therapy. If you'd like, I can quickly go through them, but I want to leave some time for questions. And I put these in because I've been getting a lot more messages around, what do you think about AI and mental health, right? So I think it's all on our minds. So want to have that discussion as well, since we're kind of, as you can see, my work's been adjacent to that. So really thinking broadly now, stepping back out to what's happening in the moment, I think it's important for us to really engage with these issues. As much, whatever your thoughts are on AI, I think the reality is we cannot avoid it, so we have to face it head on. And I think the reality is that there are benefits and limitations to these technologies, right? They're extremely available. People often suffer in the middle of the night. They can access something in the middle of the night. There's anonymity, stigma can be reduced. They're pretty cheap, right? Our services are not very cheap usually. They could potentially provide early intervention or at different times. There are obviously limitations, right? There aren't humans overseeing this. There are privacy issues. There are misdiagnoses, not only misdiagnosis, but in some cases we've seen these chatbots can make problems worse, right? And I think the reality is we don't quite know how the pros and the cons balance out at the moment because nobody's assessing what the pros are, and we get a few anecdotes about some horror stories. We also know that people are not very comfortable with the use of AI in their healthcare, and at the same time still engaging in it. I also think a lot of us don't really understand how it works, right? Or where it might be applied or how we're already using these technologies. I think one example is a little bit older, and there have been others since then that highlight some of the issues, some of the core issues around using AI and mental health. Coco is this platform that provides kind of support for mental health, and it relies on peer support via kind of the social network model. And so what they did is, in the early days of ChatGPT, they used some AI-generated messages and asked people to rate what they thought of the messages compared to messages generated by humans. And they actually, users rated, and this has been replicated in other studies, users rated AI messages as better than humans until they found out that they were AI messages, right? So there's this trust issue that's going on. And I think it's really important to think about how these things are applied and have transparency and rationale, right? I always go back to rationale. How are we using these technologies? What are we using it for? And really building up the trust so that people don't feel, particularly in interventions that rely on trust, that can really harm the intervention. And unfortunately, there are a lot of negative things that can happen with these models and what data gets put into these models, right? There's just one example of how AI models can be manipulated. We've heard horror stories around using these models for when people use them in their daily life and how they can contribute towards increased delusions. And really feeding them. And this is a really built into the design, unfortunately, right? Because a lot of these chat bots are designed to have you continue to engage. So if you've ever used one of these things, they always ask you a question for what you want to do next, right? So all the models are designed for, when we think about from a reinforcement learning perspective, is for the user to continue engaging. That is what they're optimized for. They are not optimized for other things such as safety. So as we design them, we need to think about how do we integrate how do we reinforce other things? How do we reinforce safety into these models? And we also need to be aware and to some extent accept the fact that people are using these tools and they're likely going to continue using these tools. Okay, youth in particular feel comfortable sharing confidential concerns with chatbots, right? That's only going to continue to increase over time. People noted that they find these technologies to be easy to access, convenient, private, non-judgmental, cost-effective, personalized, right? How can we get our interventions to do more of this if we want to compete? And or how do we integrate these things into our interventions is more likely the question. What are people worried about? Privacy and data concerns, no access to human support, right? How do we integrate that? Limited ability to handle complex emotional issues, misdiagnoses, inaccurate advice, etc. It's a real Wild West out there. Would Americans prefer if AI chatbots were integrated into existing services or standalone? As you can see, most people want these things integrated into their care. And it is scary, and I think in particular, when we're thinking at the big picture, there's so much liability and so many reasons not to do it. And I think that we may not have a choice. It's more a matter of how rather than if. In digging in deeper into how these things do at therapy, some folks looked at large language models and how they engage in therapy, and in general found that models are not very good at therapy, right? They tend to move towards problem solving right away, as opposed to processing. So they are not there. They serve a purpose likely for maybe for problem solving. They might actually be pretty helpful to walk you through what are my choices and how do I choose, et cetera. But for the actual process of engaging in therapy, reflecting, et cetera, they're not quite there. I'm gonna move forward a bit to give us time, but really some of the key takeaways, in my view, the train has left the station. I know there's pushback, and we do need to be mindful about how fast these things move and where they go, but I think it's happening, right? It seems clear. So now what are the guardrails? How do we develop those? How do we improve linguistic and cultural diversity so that these models can be relevant to more folks? And the liability issues continue to be problems. Thank you all so much for bearing with me, and thank you to all the many people who have really contributed to this work. think we have a little bit of time for questions, if folks have any. Barbara.
Thanks, Adrian. That was really thorough and gave us a lot to think about. My question's around the diagnosis piece and assessment. So I'm a big evidence-based assessment person. And it's really hard to teach really good diagnostic interviewing skills that's based on, good clinical care and, the rapport building and also understanding, what's this versus that and how to do differential and case conceptualization. How do we do that with this? I imagine that my sense is that people self-identify, right? I'm depressed, like a flyer goes out. Are you depressed? Yes, I'm depressed. But I could also be depressed and have PTSD and smoking a lot of weed, right? So I wonder if you could speak to how we integrate assessment a little bit more, which is what comes to mind when you talk about diagnosis for me.
Yep, and specifically with regards to kind of AI models and things like that, So there are many different ways to do this, and this is where it becomes some of the things we can actually do, some of the things we can't. So we think about these types of models. There are what are called foundational models, which are like ChatGPT, Gemini, the existing models, right? And what we can do is we can help to do some prompt engineering. So we can train them a bit to say, okay, focus on assessment, make sure to ask these questions, and kind of provide some guidance around how to engage in this problem, right? So that's kind of one approach. But things are still going to be loose because the model just has so much data within it, and it could go its own directions. We could develop our own models, which are much more targeted, right? And stay within their lane much more. But that requires working with folks who are able to develop these kinds of models and algorithms. I think ultimately, with the use of any of this, particularly in mental health, is being really targeted with what we want to know, right? The challenge with these chatbots is that they can tell us about anything, right? They can deviate and start talking about things that are not as relevant. And if we have a specific goal, I think that, for example, it could be useful to say, here are some of the symptoms that I see, right? Generally speaking, what are some possible diagnoses that I might consider, right? That is a starting point that can get the conversation going, right? And even as a training tool, we can think about that. And then the question is, okay, what do I need to know to go deeper into figuring out what that is? And that's how we can engage, let's say, folks in training and things like that. So we have to figure out how to apply these things. They can be quite useful, but we can't just let them run on their own, right? And that's the part that's challenging, because it's very tempting to just let them do all the work for us.
Thank you, Dr. Aguilera. Your work is so inspiring, and to see how you've really continued this thread of health equity throughout your entire portfolio is really impressive. And not to be a bummer, but I'm wondering what advice you would have for folks who want to emulate that, especially junior folks who are feeling really discouraged about how to find funding for this type of work and keep the common thread while still aligning with the ever-changing nomenclature that we're needing to adjust to.
Yeah, I think it's extremely challenging. It can be very disheartening. And at the same time, I think that there's a case that we can make, and maybe we have to use some different vocabulary at times. The reality is that at the base level, we can even make the economic argument, right? These things cost money. For systems, they cost money in terms of social problems. And there are real reasons to work with folks who have high levels of need, above and beyond morality, even which many of us may be driven by. It's the right, good thing to do. And that is important. And it's also the practical thing to do. And I think that there's a case to be made about that. And I think we need to, also remember that part. And I think we need to do more of that now, because I think it was, to some extent, there was this understanding that we're all on the same page, and now we're realizing, well, maybe we're not all on the same page. So we have to, I think we still have to maybe convince folks, make the case, but I think we can continue to make the case. I, at this point have started my trading when these things weren't as well accepted. We had to make the case. And I think in some ways we've still moved forward enough. But I think that, fortunately, some of this has settled a bit, where our projects focused on Spanish-speaking populations are still being funded. I think issues of health disparities are acknowledged. I think the question may be how you approach those disparities is up for debate a little bit, and there's some real challenges. But I think that there's still room to move forward. And I think that particularly coming together and really just doing the work is my view. And that's what I tell my team, particularly during this time, is finding ways to do the work and move some of these things forward. A lot changes around us all the time, but we're the ones that are closest to the ground and see these things happen.
Thank you.
Yeah.
I mean, I love working with you, and I just love your work, and I think this really is the right. You're asking such good questions at such the right time. I know this is like a body of your career, so I know that you're arriving at such a wonderful time, especially for the world as it is today. So I think one of the questions I have is, when thinking about endpoints, in terms of clinical trial endpoints, or how to measure what we're doing to what effect, and it's differing by technology, because that's kind of one of the messages that you've said, is that pick the right endpoint depending on how you're leveraging the technology. Mm-hmm. And so do you see that it's, when you're using texting or using generative AI, is it more looking at, when you're thinking about that as like an adjunctive intervention, are you thinking about that more in terms of the reinforcement and the engagement, or is it the clinical issues in and of themselves? And how do you think about that? Because I think for me, as I'm thinking about my own trials, thinking about how to sort that out, because that's some of the tough part that I'm struggling with.
Yeah, I think that's a great. It's a great question. I know there's a lot to it, but I think it reflects the fact that we often, frankly, overcomplicate things in many of our interventions. We try to address everything. Even worked with folks, especially if you're developing an app, you're like, oh, can we add this? Can we add that? Can we do mindfulness? Can we do walking? Can we do this other thing? And then our message gets muddled, right? We don't know what we're targeting. And so I think it is important to start off with, what are we targeting? What is the key problem? And at least order these problems. If nothing else happens with my intervention, what is the one thing I cannot lose, right? And so in some ways, I think less is more, which is one of the reasons I think, something as simple as physical activity is a pretty cool outcome, because it's so broad, right? We looked at diabetes and depression, but you can address all forms of chronic illness are going to be improved by physical activity, different aspects of mental health. And I think we need to tweak it a little bit, because we didn't find as many effects on depression. We're kind of looking at that data now, and maybe we missed something with regards to pleasant activities, or it's too crude of a measure. But the point remains is, what are we trying to do? Where are we going to get the most bang for our buck? And really trying to go in on that. Because I think too often we try to do a lot. At least we need to kind of prioritize what are the most important things. Once that's covered, then we go on to the next element, right? Kind of like what we would do in setting up a psychotherapy plan, right? We don't try to address all of somebody's problems all at once. We kind of take the highest priority and focus on that.
Thank you for a really great talk and really inspiring work. 2 questions for you.
Yep.
The first one is, what are the things that one needs to be mindful about engaging low-income, vulnerable populations in digital health kind of interventions?
Yeah.
The second one is, what is the future here, right? Like we're talking about incorporating digital tools, digital thinking, conceptualization, or even like platforms, right, into the work that we do as clinicians. Last I checked, though, creating an app is a lot of work.
Mhm.
And it takes a special kind of ability, knowledge, a lot of resources.
Mhm.
That's not the direction we're going. What is the direction that you foresee?
Yeah, that's great. So the first question is a little bit more straightforward. So I'll try to address that one. I think in a lot of our work, our experiences, the most important thing in working with our community partners, our patient partners, is building trust. And I think right now more than ever, trust is so important. Not only are there issues around trust regarding technology, but there's trust generally, in the immigrant community. There's so much fear and reticence to engage with anybody who has any sort of official capacity. And we're able to make some gains when there is trust. And I think that is just such a core element that we need to be mindful of. I think sometimes we also need to do maybe a little bit of slight nudging and convincing. I think, working with my recruitment team about how do we talk about these things with patients, right? Sometimes we don't want to coerce, obviously, but we actually need to do a little bit of education while we're talking about these things. Because if we say, do you want to participate in this project using AI, people have their own visions of what it is, right? We need to create a shared meaning of what these things are, what the purpose is, et cetera. So I think that's what I would say there. In terms of the future, I agree with you that we can't all build our own apps, but the apps are being built for us, right? And so we're going to engage with them in one way, whether we want it or not, right? They're all going to be integrated into the EHRs in some form or another, into the different tools that we use. And so I think it's really important for us to be intentional so that we are using this technology as opposed to the technology using us, right? That's where I think we need to be mindful of in terms of training and things like that, right? And some of us that are doing research can do the development, work with developers, things like that. But even for clinicians, I think being intentional about how this is applied. Thank you all so much.